Greetings, friends. I'm Dr. Sanjay Gupta. I'm Senior Consultant Physician and Diabetologist and Director of SG Diabetes Center in North Delhi. We are doing diabetes care since last more than 30 years, and our center takes care of all complications of diabetes and is actively involved in major clinical research. Uh, Today, I'm going to talk to you about a very interesting patient, and this sort of case scenarios give insight about the practice of diabetes care and how modification of drugs can really help our patients. You will see such patients almost every day in your practice, and then we have to realize what help can be provided to them by looking at their drug profile. Now, this gentleman was a 47-year-old male who was a corporate manager. He has diabetes for 8 years of duration, hypertension for 3 years. He has a family history of CAD in his father, who has already got a bypass surgery done. He is a corporate manager, smokes daily, and has occasional alcohol on parties. He doesn't exercise much, and he has a lot of stress currently because of a lot of COVID-related issues. He has been a diabetic for almost 8 years. In first 1 year of his life, he was not taking anything. He was taking only Ayurvedic drugs and other thing. And then he was on sulfonylurea metformin combination. First, he was on metformin for almost 6 months, and then kept on to sulfonylurea metformin. Last time he got his evaluation done, and he found that he had a very high A1C, and it was 9.1, and he had a very high blood sugar at 156 of fasting and 220 postprandial. He is also hypertensive, so he was also concurrently taking telmisartan 40 milligram, rosuvastatin 10 milligram, and his physician saw his blood sugar values and said he was on full dose of sulfonylurea, 4 milligram of glimepiride per day, and metformin of 2 grams per day. So he added pioglitazone 15 milligram twice a day and voglibose 0.2 milligram 8 hourly. This he's been taking for next 3 months, and then he reported to our clinic. At that time, on examination, he had a blood pressure of 146 by 96, pulse of 80. He was complaining that since last 3 months he has gained 4 kgs of weight. He's also noted that whenever he comes back from the office, there is some edema on his feet. And around 3 o'clock or 4 o'clock, when he's very often he is not able to take his lunch also, he just takes a sandwich or mixes. So he says around 4:30 he has a lot of dizziness, and then he has to actually leave work and go for a coffee. So apparently he has these issues, and in night also he's complaining that occasionally at 3 o'clock, 4 o'clock he feels bad, he has bad dreams. And all these can be correlated to a degree of hypoglycemia which happens. And we as physicians should realize that patients who are gaining weight and patients who are having these subtle symptoms are actually maybe having hypoglycemia. Now, when we thought that sugar must be lower, so we checked his blood sugar was fasting was 140, postprandial was 196, and his A1C is 8.6. So he's not controlled as yet. His blood sugar values have come down, but he's still not controlled. His creatinine was 1 and the EGFR was 89. His current body weight was 175 at 86 kgs, which was at the height of 175 centimeter of his height. The BMI comes out to be 28. So what we have seen is this person is still not controlled. He's probably has some degree of hypoglycemia. So we also did his evaluations for his KFTs, and apart from that we did a macroalbuminuria evaluation, and his albumin creatinine ratio came out to be 46. So his macroalbuminuria also positive, because he was having this little swelling feet and tiredness. So we did a CV evaluation, the ECG was normal, chest X-ray was normal, and NT-proBNP and echocardiography came out to be normal. So here we see a person who is at a very high risk of cardiovascular instability. He's has all the factors which are increasing the so-called multiple risk factor individuals. So we decided to, and he was really troubled. He was having a lot of hypoglycemic events in between. So we changed over the entire treatment plan. We continued with this telmisartan, continued with the rosuvastatin, and we stopped all other drugs. He was put on only on metformin 1 gram twice a day. Along with that, he was put on an empagliflozin 25 plus linagliptin 5 milligram combination. Now, whenever we take such combinations, look at the intrinsic value of this combination. The person was quite happy, because what has happened is suddenly out of 9 tablets that he was taking for his diabetes Now he was on only 3 tablets, 2 tablets of metformin and 1 tablet. So that itself increases the compliance of the person. After 3 months down the line, when the patient came back, the A1C was 7.4. So I wish to point it out to you friends that when you use over and above, all the 3 drugs that he was taking, once we shifted all those drugs, we still had a wonderful fall of A1C of 1.2. And EMPA-LINA combination is quite potent. Unlike both the drugs separately, when you use 0.6 or 0.7 sort of A1C fall, but when you use a combination and people who have a baseline value of 8, 8.1, you get a very good fall of A1C. So a very gratifying fall of A1C of 1.2 was seen in this patient. He lost 5 kgs of weight and his blood pressure was 130/80. We did not add any other antihypertensive. So I wish to point out the advantages which in this particular patient we had. Number one, we had very good glycemic control. We had an A1C fall of 1.2. We were very close to the ideal values now. We had a significant weight loss of 5 kgs. He lost entire weight gain that he had in last 3 months, and we had no further episodes of hypoglycemia. So here you have a person without any hypoglycemia at all. Furthermore, we did not require to add. See, initially when he came, he had a higher blood pressure. He had a blood pressure of 146/96 and we did not add any other antihypertensive drugs, and we had a good BP control of him. Now his blood pressure is 130/80. This is an additional advantage of using, a salt like SGLT2 inhibitors and empagliflozin 25 milligram will give you a 5 to 6 millimeter fall of blood pressure, and very often potentiates the actions of the other antihypertensive drugs, including ARBs. His edema totally disappeared, and along with this loss of weight, you had certain other findings that are going to benefit. We know that there are going to be currently the treatment of all diabetics should look into the cardiorenal benefits. This person, we checked, his macroalbuminuria also disappeared, and this is very important because there are multiple ways by which this macroalbuminuria disappears. Glycemic control itself contributes, blood pressure control itself contributes. We know even linagliptin in trials have shown that they stabilizes and causes fall in macroalbuminuria. SGLT2 inhibitors are well known to reduce proteinuria. So we have a macroalbuminuria reversal. So look at the advantages of the person. Apart from this weight loss, blood pressure control, glycemic control, we have hidden benefits. We know that empagliflozin will cut down the risk of MACE events, will cut down the new onset heart failure. And we have seen the number of studies which have been right from EMPA-REG onwards. We know that empagliflozin increases the lifespan of the person and decreases the risk of new onset of cardiovascular events. So friends, this is an example of just modifying, the drug treatment plan and reaping benefits all over, right from the visible benefits of convenience, control of multiple risk factors, and long-term benefits that these patients have in their cardiorenal profile. And we should consider this sort of EMPA-LINA combination in such scenarios, and always look at their other benefits, the extra glycemic benefits that it provides. Thanks a lot for listening to me. Thank you very much.